Okay, let's go.
Welcome to The Explainer. Today we're breaking down one of the most common, yet maybe one of the most misunderstood, classes of medication out there: antidepressants. Okay, so let's just dive right in. To really get a handle on antidepressants, you have to picture a time when the options for treating depression were, well, pretty grim. We're talking things like electroconvulsive therapy. The story here doesn't start with some brilliant scientist designing a cure. Nope, it begins with a series of really fortunate accidents. You heard that right. The story of antidepressants kicks off not with a targeted search, but with a surprising side effect that popped up in a totally different area of medicine. What's so wild about this timeline is the pure coincidence of it all. Back in the 1950s, you have these two completely separate things happening at once. Doctors treating tuberculosis patients with a drug called iprosonazid started noticing something strange. Their patients were becoming unusually happy. At the exact same time, a Swiss psychiatrist just messing around with different compounds stumbles upon iprimine. So these two drugs, one for TB and another found by pure chance, become the world's first antidepressant. It was the very beginning of psychopharmacology. But here's the catch. While they were a total breakthrough, these early medications, known as TCAs and MAOIs, were kind of like blunt instruments. They were really tricky to use. The MAOIs, for instance, required you to be on a super strict diet to avoid life-threatening blood pressure spikes, and the TCAs came with a high risk of overdose. Clearly, something better was needed. So, let's fast forward a few decades to the late 1980s. This is when a seismic shift happens, with a whole new, much more refined type of antidepressant hitting the scene. This new class of drugs, called selective serotonin reuptake inhibitors, or SSRIs for short, were absolute game changers. I'm talking about fluoxetine, which you probably know by its famous brand name Prozac. It had way fewer side effects and was so much safer, which meant doctors could prescribe it with a lot more confidence. But you know, this revolution was kind of a double-edged sword. On one hand, it brought relief to millions of people who probably never would have gotten help before. But on the other hand, because they were so easy to prescribe, it sparked this huge debate. Were we getting a little too quick to medicate complex human emotions, especially when you've only got like 15 minutes in a doctor's office? Okay, so with literally millions of people using these drugs, you'd think we'd have them figured out down to the last molecule, right? Well, the real answer is way more complicated and honestly, way more interesting than you might think. For decades, the story we were all told was the chemical imbalance theory, or the monoamine hypothesis. You've definitely heard this one before. The idea that depression is just a lack of certain brain chemicals like serotonin. It was a neat, simple story that was easy to understand. But here's the twist. The scientific community, they pretty much all agree now that this super simple explanation, it just doesn't hold water. Depression is way too complex to be boiled down to just one chemical being out of whack. That chemical imbalance theory is now seen as way too simplistic. In this quote, it just nails the central paradox perfectly. Think about it. We've been using general anesthesia for over a century and a half, and we still don't know the exact mechanism for how it works. And it's kind of the same with antidepressants. We know they help a lot of people, but the exact why is still a mystery we're working hard to solve. So that leads to a pretty big question, right? If we're not 100% sure how they work, and there are so many different kinds out there, how in the world does a doctor pick the right one for a patient? Well, first off, the field is absolutely crowded with options, and they all work in slightly different ways. And this brings us to a really crucial point. There is no single best antidepressant, period. In fact, the biggest study ever done on this, called the STAR*D trial, proved that no one type is automatically more effective than another. So instead of looking for that one magic bullet, clinicians get personal. They look at the nitty-gritty details, like the side effect profiles of the most common choices. For example, fluoxetine has what's called a long half-life, which just means it sticks around in your system longer. That can be super helpful for someone who might forget a dose now and then. Then you've got sertraline, which can be great for a person who also has anxiety, but you gotta watch out for some stomach issues. It really is a highly personalized process, like being a detective. A doctor is gonna look at everything. Your specific symptoms, like are you sleeping too much or not enough? Other health conditions, what's worked for you in the past, the whole shebang. It's all about tailoring the medication to the person, not trying to fit the person to the medication.
And really, it all boils down to this one simple truth. A medication can't work if it's just sitting in the bottle. So the #1 priority is finding a drug that someone can tolerate well, because that's the one they'll actually stick with.
But of course, treatment isn't always a straight line. Let's get into the stuff you've probably heard debated online or on the news, the real-world controversies, from the placebo effect to some much more serious risks. A huge point of debate is the placebo effect. And what's fascinating is that in clinical trials, somewhere between 30 and 40% of people with depression get better while taking a totally fake pill, a sugar pill. This speaks to how powerful the psychological side of treatment is, just the hope and expectation that come from taking action. And you see this effect across all of medicine, by the way, not just psychiatry.
Now for the most serious concern, suicide risk. And here, the data tells a really specific story that hinges on one key factor: age. For adults over 24, the big studies just don't show a clear increased risk. But, and this is a big but, for young people under the age of 24, the evidence does point to a small but very real increased risk of suicidal thoughts and behaviors.
And that is exactly why the FDA issued its most serious type of warning. It's called a black box warning for antidepressant use in children, teens, and young adults under 24. It doesn't mean the drugs can't be used, but is a huge flag for doctors and families saying, hey, you need to monitor this person extremely carefully.
So after all that, what's the big takeaway here? Well, it's that the story of antidepressants is one of nuance. This isn't a simple case of a magic bullet. We're talking about a powerful tool that was stumbled upon by accident, whose inner workings we still don't fully get, and whose use demands a really careful, individualized approach that balances the benefits against the potential risks.
And that leaves us with a final thought to chew on. As our understanding of the brain and depression gets deeper and deeper, the whole conversation is going to keep evolving. It's moving away from a simple, do they work, to a much more sophisticated and much more important question. How can we use them in the wisest way possible for the right person at the right time?